Welcome back to the Sports Medicine Project team. I tell you what, it brings me immense joy to be back on the podcast. We have, of course, been on hiatus. We released an episode a couple of weeks ago with the lovely Femi girls, which was great, so well received. There were so many great clinical insights and just a good understanding. I mean, I don't know what it is learning around kind of physiology, both male and female. I just find it so fascinating. So it was great to have those guys on. But the hiatus has been for good reason. Kelly and I have both been incredibly busy, and I know we said on the 2 episodes ago, but Kelly's now working at the university. I'm just starting my PhD. We've both been doing some speaking and some teaching, and it's just gotten away from him. She's also got a rescue greyhound that's taken up a big spill. But I've missed the podcast so much because online and social media it's just so difficult to be able to have a good quality, nuanced conversation. And every time we talk around any topic, even when I create a reel on Instagram or post something on LinkedIn, it feels like it's so much longer than what it should be. And I know without a doubt, 7 to 15 seconds is probably the sweet spot for any kind of content that you're creating to be most engaging. But there's just no way that you can speak about it properly and acknowledge all the different facets of, if we're talking around an Achilles tendon or patellofemoral pain or foot orthoses or pain in general, whatever it may be. So I'm really excited to be doing this again, and we have plenty of episodes that we have recorded. We just hadn't had time to release them and edit them, but now I've got a bit more time throughout the week to be able to doing it. So I'm really excited. We're kind of going to split it between, having an expert come on, as an example, today's episode is with Dr. Myles Murphy. And we're also going to talk about just some other topics that, will come up throughout the week, maybe something that I've created on social media or spoken about, or something that I've seen, like just to acknowledge. I did the Gold Coast Marathon 3 weeks ago. And I thought, people would probably be safer if they were running in maybe this new super trainer category than say in a performance shoe, or better known as a super shoe with a narrower midsole and not the most comfortable fit. And I thought, you know what, you could talk about that for 25, 30 minutes, and that could just be a nice resource for people to be able to work through it. Of course, I'm biased because my PhD is going to be around running injuries. So I'll be doing some episodes around some of the things that I learn and read and try and bring a little bit more good quality information into the running space. But despite all that, we are pumped because today's episode is with Dr. Myles Murphy. Now, if you don't know who that is, go and give him a follow on LinkedIn. But he is a clinical physiotherapist and an early career clinician researcher from the Nutrition and Health Innovation Research Institute at Edith Cowan University. And he works clinically. Now, you know that this is the thing that really gets me going in the morning. Whenever I'm speaking to someone or listening to someone, maybe online or doing a course, when they tell me that they're doing research and they're also working clinical, I feel like it's almost that I call it the golden trinity of you're teaching about something, you are researching it, and then you're implementing that clinically. It's like the golden triangle, I think, in my mind, of like being able to speak to the nuance, because as we know, the research can't acknowledge everything, but if you're implementing that in the clinic, you can talk around where it's a little bit different. So he's doing that. And he is consulting at SportsMed Subiaco. I definitely pronounced that wrong. And has worked and consulted with a variety of elite sporting teams. He has completed his PhD part-time at the University of Notre, Australia, investigating the different mechanisms related to pain and dysfunction in people with lower limb tendinopathy. Get that? That's up our alley. And we speak a lot around Achilles tendinopathy, but tendons in general. And you think, even just to talk about a tendon, I mean, you can't do it in a 7-second or a 3-minute reel. You've got to have these long format conversations to be able to acknowledge everything and really talk through like, hey, what do you do as an expert in the field where this case comes into your clinic? The person who their level of pain is still a 5 or a 6 out of 10, they're quite sedentary and they're getting those level of pain just with doing things day to day. How do you unload that person? Do you put them in a boot? Do you put them in a wheelchair? How do you speak to them about their pain? Like, what are you doing as the expert? And these are some of the questions we ask. So I know you'll get a lot out of that. So his research involves investigating the drivers of pain and impairment in people with lower limb musculoskeletal injury and disability, as well as novel neuroscience interventions to address these impairments. So, we're talking everything here. And this episode, I think we certainly acknowledge the research, talking about, compression-related torsional Achilles versus more tensile and how to manage them differently. But you can just tell when you're listening to someone that they're seeing these cases in the clinic. And when you hear from people speak around these topics, I almost feel, or I feel as though I can tell, because when you listen to someone who is seeing it, they always kind of have an acknowledgement of only in this particular case, or not always. Like they might say, great, if you see anyone with Achilles tendinopathy, loading is the best thing for them. It's always going to be the best thing for them. And this is what the best systematic review will show. And then when you talk to someone like, Myles or other people that had on the podcast, they'll acknowledge that and say, yeah, in the majority of cases it is. But there are some cases that you see where, their level of discomfort is so high at the moment that just adding exercise onto that, without a goal may not be entirely beneficial. And they might just need to get comfortable with their ADLs and look at some more unloading and then bringing that in a little bit later. And I think you can only really have that happen if you experience that within the clinic. And that's always been something that I've spoken about with some of the foot and ankle related conditions, like especially in the forefoot. Compressive plantar heel pain is another great example where, quote unquote, they've been over exercised when they really just need some cuddling, some offloading. They might just need a soft inner sole, some heel lifts, a nice cushioned shoe, and some taping, for a couple of weeks to settle down the heel or to offload that plantar plate. And then we can start to bring in the rehab. And we kind of think big picture, principle wise, if I'm trying to unload someone, they come in to see me, they have discomfort, without a doubt, load modification and education is always going to form a big part of my treatment plan. So principle-wise, I'm trying to unload them. So that loading, can I say that it's vastly different from the extra loading that I'm going to give them? So, your Achilles is sore. Oh, don't do the things that aggravate your Achilles, because when your Achilles is loaded, it's sore. But let's get you doing some exercise and movement. Now, I know, of course, exercise can help in many a way with pain, but we don't really understand exactly how, and maybe, we're not as great, or I'm not aware of any research yet to be able to categorize to say, yes, you will benefit from exercise with pain, whereas you don't, other than, asking them and them telling that in the history, but making it individualized to the person, especially when it comes to movement for pain. You're going to hopefully learn that from this podcast. So that's one of the topics that we speak about. But anyway, I'm rambling on too much. Let's get into this podcast with Dr. Myles Murphy. Pumped up to be back, and we'll see you guys next week. Catch you later.
So even at the moment, like what's a week look like for you? So you're clinician researching as well?
Yeah, so a week probably, as a nutshell, just looks like an atomic bomb going off and trying to contain the damage.
Yeah.
I'm a bit everywhere. So I do research work, which is based out of Edith Cowan University. And then I also have a clinical role at SportsMed Subiaco, which is a multidisciplinary sports medicine practice in the middle of Perth. And I split my time between both of them. But then I also do consulting for teams and organisations as well. So on any which day, I don't really know where I'm meant to be unless I look at my diary. But it's a bit of a mix between research and the clinical practice side. And really what I'm seeing, I guess, from a caseload point of view is probably more persistent or non-resolving cases as opposed to the extremely acute tendon. I'll still see some of them through some sports work that I do, but predominantly it's the really complex cases that just have had things thrown at them and just aren't getting better.
Yeah. And have you always worked within research and a clinician, or were you a clinician first and then come into research? Like that's got to be I did something similar, and I find it's the best split of seeing that and also learning about it.
Yeah, so when I did my undergrad, I had, as people do, some people do honours, and I remember going to the honours thing and going, oh my God, there is no way I'm doing that research. That sounds absolutely lame and pathetic. So I went then to do a postgrad cert in sports physio, and then did my sports physio masters. And during my sports physio masters, we had to do a research project, which I know most of us sort of grumbled about and were dreading and We didn't see why we had to do a research project when we're doing a clinical master's. Really lucky to be paired up with a couple of amazing supervisors. So Joe Kemp out of La Trobe Uni and Anne Smith out of Curtin Uni were a couple of my supervisors who are both extremely well-known physio researchers, obviously. I think it really changed my view on how research can be enjoyable, and it's not just for dreary old boring people. And after that, working in sport, I started to just get really frustrated at how sort of little we knew about certain things. Is that, we portray, I think, sometimes to everyone that we know everything and we have the solutions and we can get everything better. But the reality is that that's just not the case. So it sort of drove me to then going and looking at a PhD, and then went through a PhD process part-time. So I worked full-time during that period with sport, and did my PhD part-time while working in sport and maintaining a small private caseload at the clinic I was working at. So that was sort of my journey to starting my PhD, and then following my PhD, which, like I said, was part-time. So it took about 4.5 years for me to get that done. Once I finished that, I started working in a split role between a postdoc research role where I was lucky enough to get a little bit of grant funding, so I was able to keep doing projects that I was interested in, and then also bridging that with my clinical work.
And when you were an undergrad, what did you enjoy? Were you the tendon guy? You like bones, rehab? Like, where did the passion stem from?
Yeah, I definitely loved the musculoskeletal sports stuff as far as I was concerned. And looking back and now being friends with some of the lecturers from my undergrad, I recognised that, my cardiorespiratory and neuro, the approach I took to those, whereas if I'd gotten 51% at the end of the year, I'd probably worked 1% too hard. So it was definitely, for me, always musculoskeletal sports physiotherapy where I had my passion, but I didn't have any particular affinity to any condition, though I think, like probably most people that really have more of the sports interest, it was probably the lower limb, upper limb extremity physio that was of more interest than the spinal, particularly over in Perth. We have probably quite a different curriculum to I know what's taught at the East Coast. There definitely seems to be a bit of a west-east divide for the way the spinal physiotherapy is taught, whereas I think the peripheral stuff is probably much the same. And that was definitely what I enjoyed most, was the peripheral musculoskeletal sports work.
Awesome. And so at the moment, as you said, you're working a little bit toward in both the clinician space as well as research. So our favorite part of our podcast is talking about our weekly recap. And so one of my cases that I was keen to chat about today, which is Achilles tendon related, but not so much in that athletic space. So one of the tricky aspects of Achilles tendon rehab I find is in the more sedentary person. So the person who has no real goals or intentions to work towards any kind of exercise-based goals. And to be honest, it's almost like something between sitting and then walking to the kitchen is what their capacity is for what their tendon can tolerate. I find that to be quite a difficult case to manage, and I can think of one case off the top of my head who I've been seeing recently, and she has quite a few comorbidities, but her Achilles tendon insertional is the bigger problem for her at the moment. It's limiting her being able to go on holidays and to travel, and she really doesn't even have the capacity to even go to the grocery store because it's quite a problem. And I'm finding trying to get her to buy into any kind of loading really challenging, because even her just getting up and walking to the kitchen is quite a difficult task for her. And I'm interested to hear your approach in managing those more sedentary groups with a persistent Achilles tendinopathy.
Yeah, you're bang on. The two groups that I find extremely hard to manage are the patient that you just described, and the other group, which is on the complete reverse, is the elite athlete who is doing everything under the sun. You could not put anything better together for them as a multidisciplinary care approach. The biggest issue is that their body's just not coping with the training demands. And they're probably the two hardest. Is in the elite athlete space is sometimes just how much training they're doing, irrespective of how much support and capacity you give them, they just can't tolerate those loads. But they're quite rare, those cases. Far more common is the situation you describe. And it's probably not just restricted to the Achilles tendon, it's probably restricted to a lot of things, but it's getting people to buy into exercise rehabilitation when there's someone that doesn't see exercise as part of their life. And what I try and do is I try and take the pain out of it. So one of the buy-in strategies that I'll use is I'll say, okay, right, what I want you to do is try and do, even if it's painful, I want you to try and do a one-legged calf raise. And if they do it, and often when they're as disabled as you described, they're unable to do a one-legged calf raise, it's usually not that sore. It's actually that they often can't do it. They're physically incapable. Is I'd say, okay, well, that wasn't even painful. And even if it was painful, if I waved a magic wand and made it not painful, how do you think your body is going to tolerate not being able to rise up onto a heel, off your heel? Because if you think about walking, you just tried to do an essential component of walking and you can't do that. This isn't something that medications, injections, surgery is going to fix, because this isn't an issue with the tendon. This is an issue with your muscle capacity and your functional capacity being so poor. And unfortunately, the only way to improve your functional capacity is to do some form of rehabilitation regime. So I try and take the condition out of it, because with that presentation, the problem isn't just that they've got Achilles tendinopathy, it's that they're so weak and deconditioned that they're really struggling. And I'll say, if you can't do a single leg calf raise, or you can't even hold, an isometric type position, how are you going to get to the grocery store? How are you going to go on holidays and do big walks and get your steps in and that sort of stuff? It's just not going to happen. And when they have the tendinopathy, often they'll go, oh, well, I can't do this because of the tendinopathy. And it's somewhat true, but the flip side of that is the only way to get the tendinopathy better is to also reverse that. So I try and really take it that it's the reason that they're so disabled at the moment is not so much that they've got the tendinopathy, it's that their functional capacity is so poor and their muscles are deconditioned and their tendons are deconditioned. And they'll often speak about, oh, well, I've had my imaging, and I'll say, listen, your imaging definitely shows that there's tendinopathy, but there's elite athletes that have gone to the Olympics that have tendons that look far worse than yours. So we know that the tendon can actually do a hell of a lot if you support all of the muscle around it. So I try and just get them into the space where they come to the realization that it doesn't matter about the pain as much, and that's obviously important, but if they want to get better, they have to improve the function. And the only way to improve function is with some form of exercise rehabilitation regime. And there's always going to be the ones that doesn't necessarily work for, that are really resilient. And it's hard with those. And sometimes you need to try and reduce the pain to give them the confidence to do the function. But I think highlighting to the patient that the function is just as important as the inability to do things because of the pain is really important in motivating that group of people.
Just speaking more about that case and getting your opinion, that there is that subgroup of population, and I'm thinking of it for myself, it's typically that older male or female who exercise just wasn't a thing for them growing up, and they never really engaged in that. The idea that we can then use their activity as their form of exercise, like, do you find for a subgroup of population, you might say for this person exactly, rather than doing a specific addressing calf capacity, tendon capacity, they can go and find something that's not as aggravating, like getting on the bike. But that's even a challenge as well, going to the gym and all that kind of thing. But also what they're doing or what they want to do, just dosing them with that. Or would you say that doesn't address the deficit? So if they can walk 200 meters and their tendon's sore, let's try 100 meters and have a rest and then try and build across that? Or would you say that doesn't really address the muscle, like for that subgroup of population?
Yeah, it's a great question. I think the key is with the tendon, they'll have very clear aggravating factors. So things that cause aggravation of the tendon in that sort of stretch shorten capacity, which is running and jumping, though not everyone does. But it can be for that really disabled, like the person you're talking about, it can be things like walking. The good thing about cycling, if you went and cycled on the bike, it shouldn't be aggravating at all for a true intrasubstance tendinopathy, because the stretch shortened through the tendon is relatively low. However, if they've got really bad problems with their paratendon, that will be really aggravated on the bike. It'll be aggravated with walking. They'll have a bit of a different condition. So I think one of the first things is just solidifying that diagnosis. And we know from a diagnosis, traditionally what we've used are things like imaging and palpation, and gone, okay, there's changes on the scan and the tendon is sort of push on. So that means you must have the tendinopathy. But interestingly, there was a study published recently that looked at when you got people to do loading, so got them to do jumping and calf raises, if you just used a diagnosis of palpation and ultrasound imaging, so changes on the structure and palpation pain, you'd almost get the diagnosis wrong in about 50% of people, because their pain isn't actually in the mid-substance or the insertion of the Achilles. So that's probably one big thing, is just making sure that the person's pathology is what I would say the true tendinopathy or the intrasubstance portion of the tendon. Because if they've got a paratendinitis or they've got irritation of the sural nerve or they've got something going on with the plantaris, you're going to have to change your management strategy. There's a quite funny joke that I remember hearing a number of years ago from Jill Cook, and she said that I think it was every Wednesday they used to run a tendon clinic, and she said by the end of it they'd almost started calling it the not a tendon clinic because the amount of stuff they were seeing that was still in and around the area and it's still related to the tendon, but it wasn't the tendinopathy that we talk of in the research is quite high. So that's probably the first step, is just figuring out what loads are aggravating the person. Because if you have got someone that's aggravated with the bike, then you're probably not thinking intrasubstance. But if you've got someone with an intrasubstance insertion or mid-portion, you can 100% get them on the bike, and that's going to really help them for a whole host of reasons and help build up some capacity. Unfortunately for the intrasubstance tendon, though, we know that unless you apply reasonably high loads to the tendon and to the muscle, your ability to rehabilitate the tendon is a little bit limited. So that's why we tend to always go for localized exercises. And in the calf, it's pretty easy. There's not that many ways you can train the calf in a multi-joint movement. But if we spoke about the patella just for 10 seconds, I know the patella is probably a dirty word when the topic is Achilles, but things like squatting, for example, for the patella tendon just don't cut it. You'd need to use leg extensions and stuff that can actually localize the contraction a little bit more to the quadriceps and the patella. Because one of the things that happens with tendons is because they're such a gradual onset injury, the body is very good at compensating. And the movement strategies that people will use will change a lot. So as again, an example in the Achilles, if you ask someone with out Achilles tendinopathy to hop, they'll usually do this lovely hop and their heel will often not touch the ground if you say do 10 hops in a row, because they'll rely on the energy storage and release of the tendon to be able to be really springy. But if you ask someone with Achilles tendinopathy to hop, they'll often slam their heel into the ground because they're eliminating the energy storage and release capacity through the heel. And they're not doing that necessarily on purpose. That's a strategy that they've developed over time to be able to hide from loading the tendon. And that's why it's really important, if it's that true intrasubstance tendinopathy, to be able to build them up in a localized exercise where they can't cheat or they can't hide. So yes, there are some loading alternatives that can help them more globally, but at the same time, you do need to be able to get some specific loads through the tendon.
Yeah, that's a great answer.
Yeah, I remember reading, that was last year. I remember reading a paper, and you would definitely be aware of it. I think, was it when they did a follow-up, it was like 1 in 5 Achilles tendinopathies weren't actually Achilles tendinopathy or something like that when they looked at them long-term. I remember seeing that. Yeah, so yeah, I agree the differentials are really important. The case I wanted to speak about again with the Achilles tendon, just because we see so much of that, the older male runner who loves running, has enough time to dedicate to good quality resistance training and has a good understanding of what's happening at high health literacy. They know what aggravates their tendon, which, as we know, is typically intensity, and they're good at modifying it and kind of changing on the fly. And, you see these people are regularly, well, not too regularly, but I might see them every 6 months to update their gym program, change some things plyometric wise. I mean, there's only so many versions you can do of a calf raise, but we're trying to see how they're going in. It's manageable and it's stable, which I know is good for tendons, but they find that there is always some form of awareness, and it doesn't take much for them to change a little bit of their load and it will flare up. And again, it's sore for a couple of days, they settle it back down. And I've got a case at the moment, a 65-year-old runner who's awesome, loves running. And we were having the conversation the other day just around him wanting to know, will this actually ever get better to the point where I don't have any discomfort? And it's unilaterally on the left side. Will I ever get to the point where it feels all right? It's definitely thicker. There's some degenerative change there, which again, we know doesn't have to change for them to get better. But my answer was, it's really hard to predict. If you've had pain for kind of 4 or 5 years, it's probably likely that you will have some discomfort here and there, and we have to be really smart and manageable with your load. At the moment, you're doing everything right, and there's no intervention to target your pain like PRP or shockwave or anything like that. They don't perform very well. But do you think that there are some physiological changes that happen to the tendon, whether it be the peripheral nervous system or something physical in the tendon, that just means they are more likely to experience flare-ups when they are under tensile compression, shear, and those forms of loads?
So I'll probably break that into two. The first is, if someone's had a tendinopathy once, they are pretty much as high risk as more high risk than anybody else, based off 2 factors. The first is that they've had the injury. So we know once you have one injury, you're more likely than anyone else to get that same injury again. And the second reason is that whilst the relationship between structure and pain is poor, we know that you've got to have changes in your tendon structure to have the tendinopathy. So, if you've had it once, we know that you've had the structural changes and you've had the presentation. You're far more likely to get it. And particularly if you're doing a sport where we know the incidence of that condition, like running, is extremely high compared to other conditions, the reality is you're probably always going to have to be conscious of your Achilles. And there'll be people that will get it once and they'll do a little bit of rest and they'll do some rehab and they'll never have a problem again in their life. So you don't necessarily need to go crazy extreme on every first-time incidence of this condition as far as going, this will bother you for the rest of your life. But if someone starts coming in with the presentation you've described or, their second or third bout of Achilles problems that just grumble and they're irritating them, it's where you go, okay, we probably need to put in a strategy for long-term of your tendon. This isn't just something like a muscle tear where you can do some lovely rehab for 4 to 6 weeks and then you're back to play and you can do everything normal. It probably needs to be more of a maintenance program. So that's one thing that I would usually advise them. As far as predisposing factors, there's not really any evidence at the moment in the Achilles that there's any form of altered sensitivity in the long term when we look at the more central pathways that we see in other conditions. So one of the tests that we use to look at whether someone's got altered sensitivity and pain modulation is through a technique called CPM, or conditioned pain modulation. And it's been shown in a few studies now that that's intact and that's normal in people with Achilles tendinopathy. There's another study that's looked at a paradigm called temporal summation, which is where you apply repeated stimulus and see if that gets more sensitive. And with Achilles tendinopathy, that's the same as a normal presentation. The only study really that has tried to say that there's widespread or central pain changes with Achilles tendinopathy is one where they looked at pressure thresholds. And what they showed was that the painful side on someone with Achilles tendinopathy was definitely more sensitive than the non-painful side. But if you compared them to non-painful controls, even their non-painful side was more sensitive. So they said, okay, well, you've got sensitivity on your painful side and sensitivity on your non-painful side compared to controls. There must be something central going on. And that's a paradigm that we use in a lot of conditions. If you've got left-sided sensitivity from a lateral elbow tendinopathy and on the right side you're really sensitive, it probably makes sense that there's maybe some central drivers. The only thing is with the Achilles, people don't run on one leg. So the problem, I think, with the conclusion from that specific study, given the rest of the pain literature hasn't supported any weird and wacky things going on, is that the reason they could be sensitive is that they've got this preclinical change, is that they might not have pain and they might not have what we'd call a clinical tendinopathy, but are they more sensitive because of the running loads and stuff that they're putting their body under? Potentially. Even if you don't have a tendinopathy, most people, if you went for a big increase in your running load, your calves and your Achilles are usually a little bit tender if you started to poke them, even though you might not have actual pain to do the loading, you're just a little bit more sore. So when you formally test that, I think it would make sense that you're more sore than someone that hasn't undergone those loads if you've got the problem coming in on the other side. So from my point of view, I don't think there's any evidence at the moment that there's central pain drivers or even peripheral pain drivers that are persistent in these cases that could cause that long-term follow-up. I think it's more the fact that you've had it once and you've clearly got the risk factor, which is the structure that's causing the problem. The only thing with the sensitivity is that we know that local sensitivity for tendinopathy can last well after the clinical pain has subsided. So one of the things I try and tell people not to do is judge their improvement based on how sore it is to poke their tendon. And because you could be back and competing at the Olympics and have no pain in your Achilles, but that Achilles could still be a bit more sore when you push on it than the other side. And it's not very well related to the function. So that's usually what I would tell those people.
Yeah, just thinking of your Achilles and people like shins is a big one. Yeah, some people you palpate their shins and they scream.
Yeah.
And they're like, "Hey, how was your 20K run?" Fine.
Sensitive. No, I had a few things to say on that too. Like I've had persistent insertional Achilles tendinopathy and I've almost reframed it in my mind as my load monitoring tool because it just like flares up every now and then, and I'll sort of try to in those sorts of cases of people who have a bit of a grumble tendon and they they do experience flare-ups from time to time, it's like, okay, well, let's just check in on what your load's been like over the last week. Maybe there has been a little bit of an increase. Can we get it back to being stable? Is that, like, I often say it's in some ways a little bit of a helpful tool to say maybe you are doing a little bit more than what your overall system can tolerate.
Yeah.
Let's just see if we can gradually kind of get things, back on track. The other thing that I had to say from that is it's almost unusual that there isn't some sort of central sensitization or obvious central sensitization with these persistent problems, because it happens for probably everything else in the body. If you're experiencing pain for those longer periods of time, and for tendons you would expect that you would be. So I'm so curious as to what differentiates a tendon from non-specific lower back pain that sticks around for a long time.
It's a great question. There's only theories with this, and I'm going to shamelessly flog one from Dr. Ebony Rio. Because I think it's probably one that makes the most sense. And one of the theories is that when you have tendon pain, when is it sore? It's sore when I start exercising. It starts to feel better, and it's a bit sore afterwards. But there's a very mechanical way the pain behaves.
Mm-hmm.
You don't get pain attacks. You don't bend forward and have it pain. It's not constantly pain and aching during the day. So one of the theories is because the pain is so intermittent, that the intermittent pain doesn't actually provide enough of a stimulus to the central system to cause those changes in central sensitization. In the way that if you've got knee osteoarthritis, your loads might not be that important, but every day when you get out of bed, you're going to be a bit sore if you're not managing it well. And, if you've got low back pain, there's a lot of fear because you could just bend forward and things could go wrong and, blah, blah, blah. It's very different to the way the tendon pain behaves. So that's one of the theories as to why it occurs, is that
I was just thinking, like, what about in that more like sedentary group where it probably almost does behave a little bit more like persistent low back pain, where it is that little bit more constant because that's their capacity being quite low, if that's different in those cases or if that's been looked at?
Yeah, so in those cases, what often tends to happen is that the tendon becomes a little bit less of the issue.
Mm-hmm.
And they start behaving, because there's a lot of other tissues that start to get involved, particularly if they've got constant pain and constant soreness, because that's not really something that is the tendon does. So yes, and when I say, and I should paraphrase this with all the research, when they say that there's not really any presence of the pain modulation and stuff, that is in comparison to healthy controls. That doesn't mean no one in the entire sample of Achilles had that. It just means that as far as the drivers of the condition, then it's no more common. So it's unlikely that is driving the condition. But if you've got someone who does have that centrally sensitized system, it might not be because of the Achilles tendinopathy, but if they've got it, like, of course, you're going to have to treat that and you're going to have to deal with that. It's just that is probably not one of the drivers of the pathology of Achilles tendinopathy. So if you try to approach your Achilles tendinopathy by treating the central system, I think you're going to get into trouble. You're probably not going to get very far. Whereas if you targeted the peripheral system, and in those patients where they've got specific comorbidities, yes, you would need to action that, because would that be a risk factor for recovery? I would expect so. The same way that I would expect someone who has who's morbidly obese to not respond as well to an athlete, to a exercise program, because their tissue behaviors are going to be completely different. Someone with diabetes is probably going to respond a little bit slower and a little bit differently to someone without, because we know from a tissue healing and capacity point of view, they're usually a little bit slower. So it's not that we want to disregard any of these things. It's just that they're probably not the main focus for every patient. It's probably not something driving the persistence of the condition for the pathology, but it definitely can be present.
Yeah. Do you have anything interesting, a case research? Kelly and I aren't going to give too much advice because anything that we say you already know. So anything you learnt this week or interesting case that you saw of the last couple of weeks?
So probably the most interesting case that I've seen in the last couple of weeks was referred by a really experienced colleague, and they were like, Myles, I've got this Achilles, and it just, this insertional Achilles, and I've tried everything under the sun. They have literally done everything, and they go, no matter what we do, it won't get better. They go, they've got no flags in their medical history. Like, there's absolutely nothing going on with this person that we can do that fixes them. So I was like, oh, great. Okay, no pressure. So they've come in to see me, and I've gone through the history, and it's this beautiful, beautiful loading program. The loads are well controlled. The patient unless they're completely lying through their teeth, reported basically doing everything to the and in the history of what they'd done and what their presentation was, I was like, really, there's probably nothing I can add. And as soon as that starts to happen, I really want to try and dig pretty deeply into why you haven't had that recovery. And that's when I start asking a lot of the really in-depth questions around medical history and medical comorbidities. And in this instance, I just said, to this person, do you get psoriasis or anything like that? And they're like, oh, not really. I was like, do you get really itchy scalp and whatnot in summer or even in winter? And they're like, oh yeah, I get really bad dandruff and an itchy scalp. And I was like, oh, okay. Do you ever get rashes anywhere else in your body? And they're like, oh, I do get the odd rash on my hands, but I think that's just if I wash my hands too much, blah, blah, blah. And I was like, oh, okay, let's get this checked out by one of the docs. So we did the full screening then for psoriatic arthritis, and they've got full-blown psoriatic arthritis. And really, that's, in my head, probably the reason this person hasn't recovered is that they've got this massive underlying inflammatory driver that hasn't been addressed in their care. So sometimes you can do the best, most amazing treatment in the book, but if there's just one thing from a comorbidity point of view, that it can just act as a complete roadblock. So this person will now go on a really high course of steroids and get the treatment that they need for the psoriatic arthritis, because it's really important not just to assume people know their diagnoses. And that was one that was big for me. And the more you read into it, you don't actually even need to have active psoriasis to get a diagnosis of psoriatic arthritis. So really digging into those questions and asking all of the different bits and pieces that could indicate inflammatory pathologies in those patients where you think you've done the best job in the world, or you've got trusted colleagues that seem to have done the best job in the world, but they just aren't necessarily going the way that they should with everything well. Because I think with healthcare and physio and podiatry and exercise physiology and all of our allied health professions, I think sometimes we just spend too long banging on with the same thing. Is that we probably need to at some stage go, listen, we've tried this for 4 weeks, we've tried this for 6 weeks, whatever it might be. We're not even getting the slightest hint of a clinical improvement. Is this going the way we want? Because in a clinic, if you're seeing people fortnightly or whatever, 4 to 6 weeks can go by really quickly. But for the person, that's 4 to 6 weeks where they're going, I've been doing everything I've been told. And usually the burden of exercises is relatively high. They might be doing it every second day or every day, depending on the program. And they're seeing a lot of time investment, but very little return. You're also then making it harder for them in the future if they do need to engage with some form of exercise rehabilitation strategy or something else. So I think always just in the back of your mind, if you're not seeing someone improve, and that was sort of my reminder with this patient, that you want to dig pretty deeply into the medical history and make sure that there's nothing else going on, because Achilles tendinopathy can present like a perfect Achilles tendinopathy, and it essentially can be an Achilles tendinopathy. But if they've got underlying inflammatory disease that hasn't yet been diagnosed, your ability to rehabilitate that successfully is probably relatively low. And that's not saying that they don't need rehabilitation, because they've still got the problem. It just means that there's probably other things that need to be thrown into their care. And it's hard if they haven't had that diagnosis.
Yeah. So in that case, was there underlying Achilles tendinopathy going on that just couldn't be effectively rehabbed until the psoriatic arthritis was treated, or was it just
exactly.
a presentation of the? Okay, yeah.
It was someone that had I didn't do the rehab initially. That was from someone else, but the program they gave was like amazing. Like it was a great program that. If I was like, well, unless the patient's lying that they haven't done what they've said they've done, but they seem pretty believable, I would have expected with that program and with everything you've done to have seen some level of improvement. But you seem to have been plateaued, which doesn't make sense. Because if anything, even just with an Achilles, if you reduce the load, you should see some form of a reduction in the symptoms. And even that wasn't really that clear, which to me starts really suggesting that there's something else going on that could be driving the condition. And that's where it's important to always remember that you can be having to treat the tendinopathy, but there can be other things medically that need to be addressed to make sure that you can actually get a successful treatment outcome, or you'll just be banging your head against the wall.
Yeah. I had a case yesterday afternoon that had presented initially with tertial Achilles and bilateral plantar origin plantar fasciitis. The most painful, I couldn't even walk, couldn't even dorsiflex the ankle, it was that sore. And I had seen a sports doctor, had said to me to just optimize some stuff at foot level. And I was seeing the rheumatologist, and I saw them yesterday at the 3-month review, and they had a strong course of naproxen, and they are like 98% better. And they said that within a week, I was like 90% better to take their medication. It was unbelievable, that systemic presentation, which that was a really obvious one, but I agree with that. It's a really good thing to look out for.
Yeah, and they get it. So we always talk about the term tendinopathy and that it's a tendinopathy, but the people with the inflammatory conditions are the group that can get the actual tendinitis, is they get a very much inflammatory-driven insertional enthesitis. So the inflammation at that enthesis is quite profound, and sometimes they'll actually have visible swelling and things like that in areas that you don't often see, and they're all like big red flags that you need to be investigating that further, and they often do need some form of targeted care, because we know from anti-inflammatory point of view that their effect on tendinopathy is often not that great. And there was some, can't remember the exact study, but I was at a conference last year that Michael Kier from Scandinavia presented at, and they'd done this lovely study looking at the effect of anti-inflammatories, because a lot of the studies have shown compared to a placebo, inflammatories just aren't that good with general tendinopathy. And they showed that it doesn't actually, a lot of the anti-inflammatories we use don't actually cross into the tendon. So their ability to actually have any real effect is quite limited for a lot of the ones that we typically go for. So I think that is also important, that if someone has a true inflammatory condition, they will get this massive effect with the anti-inflammatories, but the normal tendons are a lot more hit and miss.
Now, in our house this week, in the last couple of weeks, Myles, Kelly and I have been at odds with each other. And I hope
Yep.
we're going to solve this debate. And we've had Ebony, we've had Keith Byer on the podcast, and we follow a lot of the tendon research because it's so interesting and so cool. But we wanted to get your opinion on the idea, which I don't know how often you hear, and you're probably sick of hearing it, but the idea of stress shielding and loading the degenerative part of the tendon, and the idea of doing consistent isometrics. And we've got a couple of published studies now, obviously not in humans, but showing that the gene expression within the degenerative part of the tendon does tell us that there is tenocyte activation, or there's something happening in that degenerative part. What I wanted to get your opinion on is not what you think of isometrics generally, but what do you think of this idea of stress shielding and loading, or doing a long, slow isometric, which loads the outer part of the tendon, and then if you hold it long enough, it starts to load the inside, and potentially might be able to change that, and likely that would have a positive, not maybe re-injury rates or pain.
Yeah, it's a quagmire really. If you read the research, it's all over the place, so it is tricky. So I'll just give my general thoughts with this. Firstly, the isometrics from a rehabilitative point of view is for some reason a really polarizing debate, which I've always found quite interesting, because as a clinician, it's so easy to do. You just go do some isometrics. Did you feel better with those? Yes, no. If they felt better, great. Keep going. If you didn't really feel that better, am I going to program them from a strength and conditioning point of view? Yes or no. But I'm probably not going to prescribe them from a pain improvement point of view. So I think that for me, that whole concept of whether you do them or not is very much based on just how they respond in the clinic. And for me, with people with tendon, we know, having recently had a study published, we know that people with Achilles tendinopathy have fear of rupture. So we know that as opposed to the general fear of movement, there's a number of studies now that have shown fear of movement isn't really that big in people with Achilles tendinopathy if you used a full Tampa scale. But that's probably because a lot of the questions on the Tampa don't really make sense for the Achilles. There's questions on there like, my accident has put me at risk for the rest of my life. And if you said that to someone with Achilles, they'd probably go, well, I haven't really had an accident. I didn't accidentally run too much and get sore. So it doesn't really make sense. But we found that if you just ask them, are you feared to rupture your tendon? Not only is it related to their symptoms, or their pain, I should say, but it does seem to be more common. So I think that is one thing you've got to consider in the population. And for me, I really like isometrics because patients think they're really safe. So I'll go, listen, can you go onto your toes? Can you go onto just one and then hold it there? And they'll often do that. They'll be a bit hesitant sometimes if they're quite disabled. If we, say, talked about that patient that you said earlier who really is in quite a state of disability, they'd be very hesitant to do that. But once they realize they can do that and they can hold it, they can build a bit of confidence there. Whereas if you tried to tell them they had to do reps of calf raises, they'll often tell you that there's no way and they might not even try. So I find that the isometrics in the early stages when they're really disabled can be a really nice way to build some confidence, particularly if afterwards they feel like there's a reduction in the symptoms.
Yeah.
So for me, the use of the early isometrics is very much based on the clinical presentation. If I had that patient that you described earlier, I'd probably try isometrics at that long 45-second hold. I'd go, yep, okay, long 45-second hold for the isometrics for the really for the person in a lot of pain. If, however, we had the other patient that was mentioned, that runner that gets the odd grumbly tendon, doing long hold isometrics is probably, I don't really see much benefit for them, because the benefits for me are, getting them to do some loading where they're in high pain states or trying to build the confidence. But if this person's running high volumes and their pain is annoying probably more than it is disabling, the benefit of that exercise might not be as profound. So that's where you would go, well, I probably don't need to go in with that long, slow hold. I'll literally start with my isotonics, my concentric, eccentric type exercises straight away. With patients, I always have this as a little bit of a continuum. So even that person who starts off initially where I said, we might get the isometric single leg because they're really disabled, they might be doing a single leg isometric because that's where they're at, but they might also be doing double leg pulses in the top half of their range isotonically. So I think it's never that I will just prescribe isometrics or I'll just prescribe isotonics. I usually prescribe them both, but it will change. So in that early phase, it's very much more bodyweight isotonics, bodyweight isometrics, long holds or high rep schemes. And then as they get better, so if we flip over to that runner who would be doing a lot of weekly mileage but gets the grumbly tendon, I tend to program 3 types of tendon loading throughout the week. I'll have my really heavy isometric day, I'll have my really heavy isotonic day, and then I'll have my endurance day. And then I say, just do the exercises 3 times a week and make sure you've got a rest day in between them. So the isometric day could actually be things like in a seated calf raise or in a leg press, 10 to 20 3-second holds, but at an extremely high rep scheme. So I might be getting them to do, if they weighed 80 kilos, and they might actually be doing 20 3-second holds. And on the leg press, it's pretty easy. You're just almost like you're walking. Or on the calf raise, it's the same thing, or in the Smith's machine, whatever you've got access to. And I'd get them to swap legs. So they're doing extremely high load, short isometric holds, which we know from some of the literature in healthy people has a good effect on tendon stiffening. The other exercises I might do, because I want to make sure that they can maintain the height of a heel raise, is I might get them to do tippy-toe walking, imagining they're a ballerina, with extremely heavy kettlebells or dumbbells. So that sort of tippy-toe farmer's walk for some distance that's going to fatigue the calf to make sure that they can maintain the height. Because one of the things we know with the Achilles is that people sometimes can get reps out, but they don't necessarily get the height. So I'd be really focusing on that. So I think in answer to the question as a whole is I use both. I don't exclusively use one, I don't exclusively use the other, but I use them for very distinct purposes. With my long isometrics, more for the person who's quite disabled, is in a little pain, and I want to build some confidence, whereas I would use short, heavy isometrics, even in someone that's returned to play, to get them doing those sort of different types of loading. And then my other rehab days would look something like a heavy slow resistance training program, but single leg, because the heavy slow resistance program has been somewhat effective in the literature, but they do it double leg, which I just don't understand. So I would always do that single leg. And then my endurance day might be something like working with a single leg calf raise to failure type exercise, working on form, changing foot position to alter the type of the fibers in the gastrococceleus that I'm trying to selectively target for this person and stuff like that. So that's the way I would do it. So I tend to have all types of loading in the program, but the rep range and the durations are very different depending on the phase the person's in.
And how do those different loads influence tendon physiology? Like I read actually this week about a longer, slower, above 3-second contraction has different physiological or can cause a different stimulus, different physiological adaptations from that versus plyometrics. And one thing I kind of want to know is, if someone's just running and they're really smart with their load, can they just run? Or is it we need to be in the gym because there's things and stimuluses that we can't get from running? And I've kind of come over to the bone research where if you do heavy resistance training, that is superior to running. And if you add it in with running, that's superior to just running alone. So I kind of want to know with tendons, is there something that we can't get from running that we should be doing in the gym? And as a result, almost everyone should be in the gym if they want to maintain healthy tendons. Not saying it's preventative, but that's what we can do.
Yeah, so I always find that adding some form of resistance training to any program is beneficial. But what that looks like will be very varied. So what we find, even with people that do ultra marathons, people who do ultra marathons and then they'll come in with raging Achilles problems. And I'll say, right, we're going to do some calf raises. And they're like, dude, I can run 100 Ks. My calves are doing fine. And then I say, okay, try and do 10 calf raises for me. And then they fail after 3 or 4. We did a screen of elite basketball last year, and we haven't published yet, but some of the elite basketballers could only do 6 or 7 reps
Crazy.
of a single leg calf raise, but they can jump ridiculous heights.
Yeah.
So we know that physiologically, just training, and whether that's running, whether that's team sport, probably has not the greatest effect on some of the physiological elements of the calf that we know help prevent injury and help increase or reduce your risk of recurrence once you've had an injury. So I definitely think people need to do both. Does everyone need to get into the gym? It would be nice, because the gym equipment and stuff that's available definitely makes life a lot easier to get the loads through the tendon, but not everyone wants to go to the gym. So you need to be able to be adaptive enough in your programming to figure out what the person wants to do and what they're going to do. Because whilst I might sit here and say that the gym will give better outcomes, the gym won't give better outcomes to a home-based program if the person never goes to the gym. So it's figuring out what they want to do and trying to optimize it within that environment. And then you need to figure out how bad it is. If it's someone that you're just putting in a general preventative calf program because you're the coach of a running squad, something like really well-controlled calf technique with heel rises a number of times a week might be more than enough to actually have the preventative effect. You might not need to get everyone into the gym and smashing heavy calf raises, but if you've got someone with really recalcitrant, problematic Achilles, you probably want to get as much loading as you can with things like the machines, because the machines really help you isolate just that muscle. So the tendon can't hide somewhere else in the movement pattern. It can't shift the weight to the forefoot. It can't shift the weight to the knee. It has to actually do it itself. And I think that's really important.
Yeah. Something that I really struggle to articulate, I think, when I'm explaining the role of rehab to patients and the role of the tendon to patients is tendons essentially acting as the springs of the lower body, or the Achilles tendon acting as the spring of the lower body. But the load that the tendon is going to best adapt to is that heavy, slow resistance to get the strain on the tendon. And then I sometimes get a little bit jumbled in my own head, and when I'm explaining that as to these two sort of contrasting roles or ways to stress the tendon, and one of them being the function of the tendon, but the other one being the way the tendon maybe best adapts to load.
Yep. So I always split them. So I always think of function and physiology. And I would say from a functional point of view, if you want to be better at being springy and be better at jumping, you need to be springy and do jumping. Okay. That's a no-brainer, right? Like if you want to get better at the actual function, you have to train the function. However, we know that physiologically there are some advantages. So we know that if you've got a stiffer, stronger tendon, you will be able to be more springy compared to if you've got more of a lengthened, sloppy tendon. And that's where, from a loading point of view, to cause physiological adaptation in the fastest, most effective way, the heavy loads are most effective. So that's why I always try and split it with patients. So I'll go, listen, to get better at jumping, you need to do jumping. Or to get better at running, you need to do running. But there's actually some tricks we can do that will be more effective to change the structure. And by having a structural change, that will also help. So I try and split it and say we're going to work on both the functional point of view with plyometrics or whatever else it might be, which is usually with their coaching staff, but then we're going to train the physiology and work on the specific elements of the structure and trying to cause that structural adaptation. And that's where I'll say the loads differ a little bit. And the other thing
that makes so much sense. I'm just like, I wish I just heard that like 5 years ago.
Just jump in there. Like those physiological adaptations, what are they? Is it more tenocytes? Is it a thicker tendon? Is it change to the extracellular matrix, more product glycans? Like, do we know what it is? And then as follow up to that, how are people getting better when their tendon structure is not changing? And I know that recent paper come out where structure takes a long time, pain can improve quite quickly. Like what are these mediators do we think? Because loading it seems to help, but it's an overstressed condition. So how do we figure that out? Two-part question. That's my fault. That's why I can't jump high. Nice to tell people that too, that what you see on this ultrasound doesn't have to change for you to get better, which is a nice thing.
I've had a few funny cases actually more recently of patients with persistent Achilles tendinopathy who have been radiographers, and it took me a while into rehabbing them for them to tell me that they had actually been ultrasounding their tendon like every fortnight to monitor changes. And so it was like this big long conversation of trying to unravel that belief and trying to educate them on the relevance of that. And because they had felt like their tendon wasn't getting better because they weren't seeing anything different on the ultrasound that they were doing. So that was quite interesting. That was 2 cases in like the space of maybe a couple of months. So yeah, that was like a reflective point for me to make sure I'm checking that for the radiographers. No, I was just, you mentioned something within that just got me thinking as well. And something that, again, I think some either patients or clinicians can sometimes get confused with. And I think it makes it challenging sometimes with managing tendons is that there's the term stiffness is sometimes used interchangeably for 2 different things. So we talk about tendon stiffness as being something that we're looking for positively with jumping and hopping and like a performance measure almost. But then there's also the term stiffness that you just then used as like almost like negatively of an experience that patients have when they're getting up and getting out of bed. And I think that there's almost some confusion with that. I wish those 2 words could be like separated in some ways. But yeah. Yeah. So then talking about stiffness as the function of the ankle, like what is that and why is that good for tendons? Yeah. Referring to, yeah.
I was just I just pulled up the paper that was like the patella stretch. It can go over to 18%, and the Achilles can go to 16. Because it was once thought it was like 4 to 6, which I've heard before. That was in vitro, but it can stretch quite a lot. As you said, the muscle contracts, so it just really elongates and comes back. I just wanted to reference I said this before, but I was just looking up on my computer. You wrote a paper. Are we asking the right questions to people with Achilles tendinopathy? The best questions, which is I encourage everyone to go and read that paper when you were talking about stiffness and what's better correlated. And like that morning, like to gauge how someone is doing, even for your clinical assessment, and when to add in and take away rehab is how it feels during, and that 24-hour stiffness, like how you wake up, is a good metric to know if you can progress. And it's also a good metric to know if you've just gone too far and you need to pull it back. Is that right? Yeah, it's a great paper. Thank you so much.
Yeah, very helpful. I have one final like tendon related question before we get into our
Tendons, baby.
fast questions. What do you see, or if so, is there any key differences in rehab with a mid-portion Achilles tendinopathy compared to an insertional Achilles tendinopathy, or are you sort of treating them quite similarly?
One question to finish, and then the 2 questions that we ask everyone, and it just come to me. No one didn't write this one down. The RAP protocol, and I have asked Ebony this as well, the RAP protocol for a periparatendon, a mix of hydroid cream, and a mix of Voltaren, contact with the pharmacist, they're safe to do it, they're okay to do it. There isn't, I think Ebony said on the podcast, there was one paper from a while ago, but like what is that kind of based off? We don't have any research on that, do we? It's just the potential mechanisms. But I got to tell you what, it really helps people. It really seems to help quite a lot. I love getting that out. You look so cool.
It's interesting. Yeah, that's a good tip though as well.
Yeah. And final 2 questions. If you could interview anyone on Earth, dead or alive, and maybe not even on Earth, maybe Mars and then beyond, and if you could do any research study, ethics don't exist in this study, and you can have as many people as you like, research any particular topic, what would it be? Surely there's just ideas running through your head. Okay. Yeah.
That's a great answer.
It's crazy.
Yeah, wow. That is a good point. That's not something that I've thought of before, but yeah, worth considering. Now, if any of our listeners want to find you, where can they go? Do you have any courses or anything like that coming up?
Thank you so much for coming on.
Yeah, really appreciate it.
It did.